5, 4, 3, 2, 1, 0. Ignite. Hi, this is Dr. Bernstein with our July 2021 edition of Dr. Bernstein's Diabetes University. Before we answer any questions, I want to remind you that my answers are generic. If you have a particular problem that you pose, I might not have the right answer because I haven't examined you, I haven't gotten a full history, haven't gotten a family history. There's very hard for me to have the exact proper answer to your question, and a good chance that I'll be wrong. But at my goal is to educate all the listeners, and if they get something out of my answer, that's the purpose. First question. Please comment on the 15-gram rule for hypoglycemia. My recollection is that this is a guideline in the ADA guidelines for the treatment of diabetes, and I believe one of the things they tell people to do if they get low blood sugars, I think they're talking about below 70 or something like that, is to eat 15 grams of carbohydrate in the form of sweet foods like crackers with peanut butter and jelly on them, jars of orange juice, etc. Now, to let you make a decision on this, I'll tell you that 1 gram of carbohydrate will raise my blood sugar about 12 milligrams per deciliter. I weigh about 114 pounds. So for a kid who weighs 57 pounds, 1 gram will raise his blood sugar double that, so 24 milligrams per deciliter. So if we want this kid to consume 15 grams of carbohydrate, it'll be 15 times 24, which would be, it would raise his blood sugar by 360. So if he has a blood sugar of 70 and you add 360 to it, it would take his blood sugar up to 430 milligrams per deciliter, which is probably going to put him into ketoacidosis. So this is the sort of game plan that the ADA plays. On top of that, the using any carbohydrate other than pure glucose, the blood sugar will gradually go up instead of rapidly. A third problem is most non-diabetic kids have normal blood sugars around 70. So you're taking a kid with diabetes and putting him into ketoacidosis just by treating the blood sugar if it's normal. So I'll let you evaluate that rule. We are a newly diagnosed family and have made many new friends on social media with other newly diagnosed families. In almost every case, families are being told to eat what you like, count the carbs, and inject the insulin. Please comment on this strategy. Well, my first comment is that you should read my book, Diabetes Solution, which explains in detail why this is totally incorrect. First of all, if you want to prevent the brain damage that occurs to growing children by having high blood sugars, you have to have consistent meals. Basically the same thing from one day to the next, in terms, at least in terms of carbohydrate and protein. And if you're going to juggle your carbo from one day to the next, you're going to be guessing at how much insulin to give them from one day to the next. And it's not just carbo that affects blood sugar, it's protein, and it's also the bulk of the food that you're eating. So if a diabetic just eats a handful of pebbles, his blood sugar is going to go up. How much insulin do you take for that? So it's all trial and error, and if you're going to be varying components like carbohydrate from one day to the next, you're never going to get the numbers right. And so this is literally telling you to have erratic blood sugars up and down day after day. And that's what happens in reality if you play the game this way. Our blood sugar spikes okay as long as they come back down. The current general indication of the scientific studies are that the long-term complications of diabetes are related to how high the blood sugar is and how long it lasts. Also, there are new studies that show that rising and falling blood sugars also increase the incidence of long-term sequelae of the disease. So it's not a good idea to let your blood sugar go up and then come down. And then, of course, the question is how long before it comes down and how far does it come down, etc. So this question again relates to the usual pattern in type 1 diabetes, which also occurs in type 2, of the rising and falling blood sugars rather than the straight line blood sugars. Do you think the obesity crisis will ever be resolved? I myself have lost a ton of weight by focusing on protein foods. This has totally removed my constant hunger. Well, do I think the obesity crisis will ever be removed? Quite honestly, I doubt it, because aside from a few oddball characters like me, there's no one fighting the epidemic. In fact, the powers that be, namely industry, food makers, diabetes associations, endocrinologists, are all pushing for high carbohydrate diets, and that's the principal cause of the obesity epidemic. Even the stores foster this. For example, you walk into a supermarket, what do you see on the end caps? The end caps are the parts of the aisles that are most visible, the end of the aisle. The end caps are loaded with snack foods and sweet foods, candies, cookies, etc., etc. So everyone that is capable of influencing us, with the exception of a few oddball characters, as I said, is pushing for you to eat high carbohydrate foods and get fat. Another way of putting it is they're pushing for carbohydrate addiction. My husband just had a heart attack. He recovered but lost his kidney function and is on dialysis. They are pushing a lot of grains and rice and juice on him. What is the proper diet for someone on dialysis? Well, I suggest that you talk to the doctor in charge of the dialysis center. I was friendly with one of the top doctors who teaches the startup and operation of dialysis centers, and he believed in very low carbohydrate diets. But he's retired, and again, the game plan may have changed for dialysis centers because very possibly many of the directors of the centers no longer know how to keep people alive. Can I preload syringes when I leave my house, or should I be taking the insulin vial along with me? You absolutely should preload the syringes. Don't take the insulin vial out of the refrigerator. If you have it frequently out of the refrigerator, it's not going to last as long as it will if it's kept refrigerated. So pre-fill your syringes. You can, it would be wise to purchase the right WRIGHT pre-filled syringe case. I think they sell them on Amazon for $2 for $12, 2 for $15. They're little plastic cases that are designed for pre-filled syringes. They maintain the setting. Your debate on D-Life with Hope Warshaw is somewhat legendary. I doubt that she would ever agree to debate you again, but what would you say to her now after all the years if given the chance? Well, my first thought when I read this question was this person's trying to get me into trouble. But then I thought a while, and I said that would be a great opportunity to learn something, maybe to learn several things. She was quite trim when we saw her in this video, which was 20 or 25 years ago. And we could, of course, wonder, has she stuck to her high whole grain bread diet, fruit and fruit juice diet, or did she wise up somewhere along the line and change what she's actually consuming herself? And how does she look? Has she gained weight, or is she still slim and trim? Did she gain weight? Does she have heart disease? Has she developed type 2 diabetes? If she has she developed the complications of diabetes? Does she have an abnormal waist to hip ratio, or is she still slim and trim? Does she have the signs of obesity? Does she have double or triple chin? And whatever ailment she has or what she looks like, is she still really following her own diet, or has she switched somewhere along the line? So all these are interesting questions. I'd be fascinated just to look at her and talk to her and get her personal history. I wouldn't have to debate her. I would just want to see what she looks like and how she's doing. And what is she doing diet-wise? With the popularity of continuous glucose monitors, I see a lot of people watching their continuous glucose monitor closely and giving multiple boluses of insulin and boluses of more carbohydrate foods to try to manage high carb meals. Is the roller coaster riding the way? In other words, should people be taking multiple doses of insulin and multiple doses of carbohydrate? And of course, if you read the literature, there have been studies of the blood sugars of people who have continuous glucose monitors. And almost all of the studies show a slight reduction of hemoglobin A1C, maybe a drop from 7.6 to 7.2%, which is virtually a meaningless drop amongst people with CGMs. So what's happening? No one is changing their diet. They're all eating high carbohydrate diets and then chasing it with insulin and maybe getting wider blood sugar swings than they had before, but certainly not normal blood sugars, which would be A1Cs under 5%. And the studies are out there in the scientific literature. A personal question. I think I heard you mention the book The Hobbit as one of your favorites. What did you think of the movies? Well, if you like the Tolkien trilogy, you should be interested in its predecessor, which is Richard Wagner's Der Ring des Nibelungen, which is where Tolkien got his idea for the whole Ring series. And in the Ring of the Nibelungen, which is an opera consisting of 4 operas and very good for geschliepen, there are periods within these operas that are absolutely magnificent. In particular, the Rainbow Bridge in Das Rheingold. There's Winterstürmer, which is a beautiful aria in Die Walküre. There's the Ring of Fire in Siegfried, and there's the conclusion, Götterdämmerung, which describes the end of the world, or at least the end of Valhalla, when the Rhine maidens get their ring back. So take a look at Der Ring des Nibelungen. The idea that diabetics should eat a high carbohydrate diet is so obviously wrong. Where did this idea come from? And why are dietitians, etc., so unwilling to confront the obvious failure of high carb diets, giving the high A1Cs of their patients? Well, you can read the history of this in a book by Gary Taubes, which is still in publication, called The Big Fat Lie. I'm not going to try to trace the history for you, but it's very interesting that When I was a medical student, I rotated through 3 or 4 different hospitals in my training, and the dietitians in each of the hospitals were all grossly obese. Is that still the case at most hospitals? I don't know. I don't maintain a hospital practice, so I can't tell you, but it would be interesting to see if the dietitians are still obese. And this was grossly obese. Please once again discuss the aldose reductase mechanism. Can you ask your producer to make a separate video from your answer? Well, we can do that, and I'll try to do it now. The story is a lengthy one, and it goes something like this. It's worth listening to if you want an education in the basic science of diabetes. The cells of the body can be broken down into 2 classes or types. Those that require insulin for the entry of glucose, which is a major source of energy to maintain most cells, and those that do not require insulin. Those that do not require insulin entail a small part of the body's mass. The bulk of the mass is in muscle, organs, and fat. The cells that don't require glucose, the cells that don't require insulin entail the lens of the eye, the Schwann cells, which are cells that line the outside of axons, which are the transmitting fibers that come off of neurons. The axons conduct the nervous signals. So Schwann cells, cells that line the outside of capillaries, small blood vessels. The cells, it's called the exoskeleton of the capillaries. These cells which wrap around capillaries are called pericytes. Peri for around, and cytes mean cells, so around the cells. There are also cells in the kidneys called mesangial cells, which live between and around glomeruli, the filtering systems in the kidneys. And these glomeruli are also what we call aldose reductase cells. They don't require insulin for the entry of glucose. So we have pericytes, we have Schwann cells, we have mesangial cells, and the lens of the eye. And because glucose can enter these cells without insulin, these cells are the earliest ones to be damaged by high blood sugars. And the higher the blood sugar, the more glucose gets into these cells. Now, these cells are capable of producing an enzyme called aldose reductase. And aldose reductase converts glucose to sorbitol. Sorbitol is not only a widely used sweetener, it's also the major component of laxatives that you can buy over the counter in the drugstore. Laxatives like X-Lax, etc., are mostly sorbitol. And why is that? Sorbitol is an osmotic agent. It absorbs water. So if you take sorbitol and eat it, your intestines will absorb the lumen or tube in your intestines will absorb water from the intestinal wall, and your stool will become watery. So that's why sorbitol is used as a laxative. Now, when an aldose reductase cell makes sorbitol, the cell swells up because sorbitol absorbs water. And if your blood sugar, after a blood sugar increase, rapidly drops, maybe let's say an hour later, there might not be enough time for the cell to swell up or for much sorbitol to be made. But if blood sugars are elevated for a long time, let's say a day or two, the sorbitol that is made will take 2 weeks to be converted to fructose. And that fructose can leave the cell, can diffuse out of the cell. But the sorbitol remains in the cell, and the cell remains swollen for about 2 weeks. And of course, if your blood sugar is high for several days, the aldose reductase cells will swell up even more. And given enough days with high blood sugars, these cells will get so big that they'll burst and die because not enough time for the sorbitol to be converted to fructose and the fructose to leave the cell. Now, that's why these cells are usually the first ones to be damaged by high blood sugars. And we mentioned the Schwann cells in the neurons. The neuropathies are very early complications of diabetes due to inactivation of nerve cells. Because the capillaries in the eyes are surrounded by pericytes, they're held together by pericytes. Let's say that one pericyte explodes. It vanishes. The capillary below that pericyte that has vanished can now a balloon outward because there's no exoskeleton holding it in place. And you get a ballooning in the capillaries of the eyes, and they have a name. They're called microaneurysms. And then if a microaneurysm bursts, you get what's called a microhemorrhage. Now it happens that the pericytes also produce a chemical that stops the rapid replication of capillaries. And if you lose pericytes, you're going to get rapid replication of capillaries in the eyes. And these new capillaries are impaired. They're weak. They're easy to burst. Aside from the microaneurysms, the new capillaries that are produced proliferate and can hemorrhage. So most retinal hemorrhages are caused by these proliferation of capillaries due to inadequate numbers of pericytes, and you get retinal hemorrhages just from the loss of pericytes. The mesangial cells in the kidneys get bigger and bigger because sorbitol accumulates in them and they swell up, and they press on the filtering apparatus of the kidneys, impairing the function of the kidneys. And eventually the glomeruli can be destroyed in part by the pressure of the mesangial cells on them, compressing them and impeding the blood flow through the glomeruli. The lens of the eye, I mentioned before, can likewise get impaired by accumulation of sorbitol, and it can get cloudy and cataracts develop. So all of these complications occur fairly rapidly and early in the course of diabetes due to high blood sugars, which get into these cells that don't require insulin for the entry of glucose. So that's the story of the aldose reductase shunt, or the aldose reductase pathway. It may have other names, but those are the ones that are more common. How is it possible for a type 2 diabetic to get diabetic ketoacidosis? Well, the easiest way is to feed him a lot of carbohydrate and make his blood sugar very high, and he can get ketoacidosis. Another way is to get him infected with COVID, and there are many type 2 diabetics who get ketoacidosis while they're infected with COVID-19, I think it's called. There's also an indication that SGLT2 antagonists, which are used to treat type 2 diabetes, can both lower blood sugar but also cause very high ketone levels in the blood. And whether this can cause an acidotic state is in question, but cited in the scientific literature as a possibility. They call it diabetic ketoacidosis, but because the people are diabetic and they get high levels of keto acids, but the true diabetic ketoacidosis involves severe dehydration. Well, I have to remind you that these SGLT2 antagonists cause a lot of peeing and therefore can cause dehydration if the patient is not consuming a lot of fluid. So you can have a dehydrated state with high levels of keto acids. Are there any diabetic complications associated with the gallbladder? Well, there is a high incidence of both gallstones and gallbladder infections in diabetics. Why that is, I'm not certain. We do know that high blood sugars predispose to infections. Even 45 years ago, when I was in medical school, they taught us that type 2 obese diabetic females have a high incidence of gallbladder infections, and it's wise to remove the gallbladder after the first infection without waiting for another infection, because the other infection can come on very rapidly, and emergency surgery in a diabetic, gallbladder surgery in a diabetic, is dangerous. So, yes, there is a high incidence of gallbladder complications in diabetes, and aside from the fact that high blood sugars foster infections, we don't know why else this is so common. Is the blood sugar rise you see from uncovered protein in the result of the protein turning into glucose directly? Okay. The blood sugar rise from eating protein is due to a lot of causes, I should say several causes, if the protein is not covered with insulin. And remember, the ADA guidelines are to ignore dietary protein when you take insulin, which is the worst thing you could do. Protein can be converted to glucose by gluconeogenesis, but dietary protein, like fat and carbohydrate, and as I have said over and over, just eating pebbles, the sheer bulk of food, can cause the production of GLP-1 in the intestines. The GLP-1 then gets into the bloodstream, causes the pancreas to make both insulin and glucagon. And since diabetics cannot make insulin, at least they cannot make enough insulin, and they can make glucagon, their blood sugar goes up from the glucagon that the pancreas is making, not covered by adequate insulin. So glucagon is also a reason why eating protein raises blood sugar if it's not covered with insulin. One crazy doctor is unimpressed with our child's A1C of 4.9%, but nearly apoplectic about the LDL of 200. How can I avoid getting through our dumb appointments, which we are forced to go to so we can get necessary insulin, without getting into a fight about lipids, LDL particle size, the true source of cardiovascular disease, and on and on? Well, if you can get him to test your child for LDL particle size, you may have some ammunition. You can also get him to test your child for oxidized LDL. My guess is that since his A1C is nice and low, he'll probably have a large buoyant particle size, which is healthy, and the lab report will indicate that. And he'll probably have a low glycated LDL, and the report will also indicate that that's a low risk, low cardiac risk. Now, if worse comes to worst, you might want to get a kindly pediatrician for your child and have the pediatrician write the prescriptions you need for insulin and so on. A lot of people do that. The endocrinologists are pretty fixed in their ways. They're afraid to do something other than what the ADA recommends. And the ADA is not fostering the well-being of patients. I hear the phrase, complications start with blood sugars above 140 milligrams per deciliter. Where does this come from? I assume it is nonsense. Yes, it is nonsense. I have not heard that expression, but I know that the ADA says that a blood sugar, that an A1C of 6.7 is normal. Now, 6.7 corresponds to an average blood sugar of about 160. So it looks like the ADA is claiming that that complications don't begin until blood sugars are higher than 160. Now, if you read the scientific articles in their journals, you can see that both heart disease and increased mortality begin with blood sugars over 100, according to the scientific studies. And if you look at studies that actually look at blood sugars as low as 80, increased mortality appears to begin somewhere around 83. So I don't know where the 140 comes from. Please explain this new phenomenon where type 1 diabetics Please explain this new phenomenon where type 1 diabetics, once lean, are now overweight, including kids. It makes no sense to me. It makes a lot of sense to me because the ADA is now pushing high carbohydrate diets, although they're in theory backing off a little bit on this. They're saying that low carbohydrate may be of value for some diabetics. But they're telling you to eat whatever you want, and what you want, of course, is carbohydrate, and the snack foods, and the Cheetos, and the Fritos, and the cookies, and so on. And that's making people fat. So not only are type 1 diabetics getting fat, but they're developing insulin resistance or type 2 diabetes. So there's now an outbreak of type 1-2 diabetes, thanks to the ADA. And for all I know, the American Heart Association may be helping them. I struggle with the dawn phenomenon. What techniques do your successful patients use? Well, first of all, I'd urge you to read my book, Diabetes Solution. And some of the things that we do is we use basal bolus insulin. The basal insulin that we currently like is Tresiba, and some people are successful at taking it on a rising and at bedtime, but some people may have to take it on a rising and at about 4 a.m. in the morning, which means setting an alarm while you're asleep. Another thing to do is to have an early enough dinner so that you can check your blood sugar 1 and 2 hours after dinner to see if it's going up. And if you really have an early dinner, you like 5 hours before bedtime, you may be able to take a corrective dose of insulin before you go to bed. Or you may find that you need less food or more insulin at dinner time. You could also consult with people at type 1 grit. That's ONE for one, type 1 grit, GRIT, and see what other people are doing to fight the dawn phenomenon. You have said that Lantus has a binding affinity for IGF-1 receptors 165 times that compared to human insulin. And the IGF-1 receptors are present on cancer cells, which may stimulate their proliferation. Can you comment on Levemir and Tresiba with regards to this? Yes, they do not. They have affinities for IGF-1 receptors that are much closer to that of human insulin. What is the lifetime of Tresiba once it is opened and out of the refrigerator? Opening it does not have an effect on its lifetime, and it shouldn't be kept out of the refrigerator. Its lifetime out of the refrigerator may be something like 2 or 3 months, but I'm not sure. I keep mine in the refrigerator, and I advise all my patients to keep it in the refrigerator. Recently, I tried a digestive enzyme product which had amylase in it, not realizing that this would cause massive blood sugar increases. I wonder if you could discuss the problems diabetics may have with pancreatic digestive insufficiency. Okay. Pancreatic digestive insufficiency is this injury to the parts of the pancreas that make digestive enzymes. It could be due to a pancreatectomy where you've surgically removed all or part of the pancreas. It could be due to pancreatitis, where there's inflammation both of the enzyme-producing cells and of the cells that make insulin, glucagon, and other hormones. Now, people with inability to produce pancreatic enzymes are going to have trouble digesting food, and therefore they may consume enzymes by mouth to digest the foods. The most common is lipase, that digests fats, and you have to be careful with amylase, which digests carbohydrate, if you're diabetic. So if you're diabetic and you're eating a lot of carbohydrate and then taking an enzyme to break down complex carbohydrates, you're asking for trouble. So if you're a diabetic and you also have pancreatic insufficiency, don't eat carbohydrate. Limit the amount of carbohydrate that you eat. You can, by trial, see if you're digesting the carbohydrate. You know the symptoms of the indigestion that you may have if you're not digesting foods, but cut way back on the carbohydrate diet. If you're diabetic, you should be on a low carbohydrate diet anyway. And you probably are wise not to take amylase, but it may be a good idea because you do need vitamins in certain carbohydrates, and therefore you do want to digest the little bit of carbohydrate that you are consuming, because it's supposed to be vegetables that are giving you vitamins. So the key to all this is low carbohydrate diet. Read my book, Diabetes Solution. I need to gain 20 pounds. Can I increase the carbs and protein amount to get to that weight? Well, if you increase the carbs, you're going to gain weight, but you're going to have more trouble controlling your blood sugars. So I would suggest that you do what I recommend in the book, which is increase the protein and the insulin. You won't have to increase the insulin as much as you would if you increase the carbs. For a type 2, when my glucose reading around 140, I get low blood pressure reading. When glucose reading is in the 90s, my blood pressure tends to be high. Well, this is sort of strange. He or she is talking blood pressure, not blood sugar. Well, first of all, I would check the accuracy of my blood sugar meter. And one way to do that is when you go to the lab to have blood sugar drawn, check your blood sugar right after they draw the blood. And although the most meter manufacturers claim that this is not the same as venous blood, the reading should be the same because the blood in the strip of a good meter is actually hemolyzed, just like venous blood is to get serum. So although they call it a whole blood glucose, you're really getting serum glucose on the accurate meters. So check your meter against the lab report. Now, you might be taking an SGLT2 antagonist, and that can affect your blood pressure. When your blood sugar is high, the agonist causes you to pee a lot, and you lose a lot of fluid, and your blood pressure drops. So that would explain it, at least when your blood sugars are high. Now, when your blood sugars are normal, if you're drinking enough water, your blood pressure goes back up. So this could, if you're taking that drug, that medication, that could explain the problem. Otherwise, I can't explain it. I've been type 1 for 30 years and have started experiencing complications, neuropathy and chronic kidney disease. The chronic kidney disease has been diagnosed with a fluctuating glomerular filtration rate, but my latest was 77, which is good for me. 77 is almost 80, which is at the bottom of the normal range. Anyway, my doctor and dietitian say to limit protein. I've watched your video and reading your book. Do you know if a patient who starts your diet with CKD, if this additional protein worsens kidney disease? Well, I don't know how much protein you have in your urine. It's not related to the protein you eat, but it's related to the damage to the kidney. And I don't know what my glomerular filtration rate was when I discovered blood sugar self-monitoring in 1969. But I do know that I had 4+ dipstick protein every time I peed, because I read an article about protein in the urine, and I started testing my urines, and until I used up the bottle of dipsticks, I tested every time I peed. And I read somewhere that if you had 4+ on the dipstick, that's equivalent to a minimum of 1,500 milligrams of protein per day in the urine. And normal is well below 300 milligrams per day. So I had pretty severe chronic kidney disease back in 1969. And I went on a low-carb, high-protein diet probably a year or so later, after I had discovered that the carbohydrate was the culprit in sending my blood sugar so high. And everyone knew in those days that chronic kidney disease was caused by high blood sugars. So in my case, the chronic kidney disease reversed when I increased the protein. Now, I can't comment on yours. I can only tell you what happened to me, and you could tell your doctors about that. I'm curious to hear your thoughts on the experimental treatment of teplizumide, a therapy currently under FDA review that is said to prevent or delay the onset of type 1 diabetes. Well, first of all, it's not going to cure diabetes. It can delay the onset. And indeed, in one study that has been disclosed on the internet but may not have been published in a peer-reviewed journal, over 2 years, 42% of the high-risk individuals who were given this drug did not develop diabetes. Now, were they compared to a control? I don't know. This particular drug is a monoclonal antibody. The monoclonal antibodies can impair the immune system. So it's very possible that people who use it can develop infections, even malignancies, due to an impaired immune system. So any drug, before it gets approved by the FDA, has to be considered potentially dangerous until they prove, until the manufacturer proves that it's not causing cancer or increased infections, etc. So it's a long way away before getting approved for preventing diabetes. Well, thanks for watching tonight's video. Our next session will be held on Wednesday, August 25th, 2021. We'll look forward to seeing you then.